So from the research side and from the clinical trials, because I know you're so active, aren't they looking at some investigator-initiated trials combining radium-223 with some of the secondary hormonal agents?
Yeah, no, thank you. So we actually have that study, and in fact, Sandy's group has done a great job with us, Ron Tutrone and Steve Bass. We have an open-label, investigator-initiated trial that we have we're enrolling right now, looking at combining oral oncolytics with radium-223 for safety. And so people are sort of been doing it sort of in terms of best standard of care ongoing, but we need the data. Getting back to everything we've talked about, we need to lead the charge on the data and the experience and showing that it is so well tolerated, as Gary said, and Richard said too. So thank you. Yeah, this is so exciting for us, combining an approved therapy, research, advanced clinic. It all fits together.
Yeah, and I think Bayer is they're going to be starting their registry trial. What is that? The Reassure registry, or I can't remember the exact acronym, but they're going to be rolling that out. And again, I think these are going to be really important questions because, as we know, we're never going to see any sort of formal sequencing or combinatorial trial with all these agents. So again, a great way to get to it, again, is through some of these registry trials. So, you know, with that being said, let's talk a little bit about the value and the importance of having an active clinical research arm within your practice. I know all of us have it. I think all of us really approach it the same way. Me personally, it gives my patients, our patients at Urology Associates, access to potential therapies that otherwise they would never be able to get in a commercial venue. I think, Sandy, you stated great. It's better patient care, and again, we can offer things. Great, and I know your research department through Ron is very active.
Yeah, the challenge always for research is who sends it, and it's always been pretty clear. It's a third really engage it, a third are okay with it, and a third go, I'm not sending anybody. We've tried to improve on that. What we have is our physician investigators, led by Ron Tutrone, but we have clinical coordinators in just about every office. It is very easy when a doctor sees a patient, when he knows the clinical coordinator is right there in the office, to walk them out to that. Also, just as a little side, to get doctors to remember, because sometimes it's hard. We have 30 studies, Neil probably has 300. But when you have a lot of studies, how do you remember what's there? This evidence-based pop-up for the EMR will also have the clinical trials that will pop up related to that disease or that 185 diagnosis or 788 diagnosis that will pop up that clinical trial that's good for that patient. So we're trying to make it very easy for the doctors. If they have to think about it, it might not get done. So yeah, we don't look at clinical trials as a moneymaker for us. I don't care if we break even, as long as we break even or close, because it is such an incredible service, not only to the patients that can afford, that have insurance, can afford it, but how valuable is it to patients who don't have the money to buy these specialty drugs, that have the opportunity to go into these clinical trials and get these advanced therapies where they otherwise wouldn't get anything and they'd be lost. That's where clinical trials made a difference at Chesapeake.
Richard?
I would concur. I mean, I think what it allows us to do is, give patients access to medications years before that they are released. So, especially with these oncology drugs. I mean, most of us have done a lot of the trials on these advanced therapeutic drugs, and for 3, 4, 5 years we're getting these patients these medications. Even if you look at the PDE5 inhibitors, right? I mean, when we were all developing those, I mean, all the people that were in those trials got the drugs years before everybody else did. So I think there's that aspect of it. It's great for patient care. I think it's also exciting, at least for me, and I think all of us would agree, I mean, part of a physician is a scientist, right? And this allows us, those that really have this interest, is to maintain that. For us to maintain a relationship, to be a scientist, and to still delve in that world and to help develop these drugs that are really great to advance patient care and therapeutics.
Gary, how did you set up your research center? I know you've got one particular physician now, right, that kind of is spearheading that?
Well, we do. We have had clinical research in our practice for 15, 20 years. I agree with Sandy. There are operational challenges to making clinical research profitable, effective. But let me say this, the five of us sitting here all represent what we think are the premier urology presences in our markets. Even Sandy, who deals with those academic institutions, has the premier urology presence in his market. It's indispensable, if you want to be the premier urology presence in your market, that you must have a clinical research department. At least that's my opinion. It is part of this whole integrated care, comprehensive delivery of options for patients. So the clinical research role, of all the things we've spoken about, can be a tough nut. It has its ups and downs operationally. It's hard to get the referrals, as Sandy alluded to. I know some groups around the country who are very profitable in clinical research. I know others that just kind of perk along and never really realize that. I think regardless of the profitability, it's critical if you want to be a premier practice in your community that you have to have this service.
Yeah. And Neil, you've been doing this, God, forever. And you know, you have probably, arguably, the most successful freestanding urology research center, and again, in not a very big market.
I would agree with everything that's been said. It just takes a lot of, you have to have a physician champion. That physician champion has to have a team, great nurse coordinators, whether it's, they don't have to, they can be an RN, they can be an LPN, an MA, but people who are dedicated, very compulsive, very patient-focused, a lot of direct, sensitivity to the patient issues. But I completely agree with Gary that it has to be part of your center of excellence. And it could be in advanced cancer, it could be in overactive bladder, ED, BPH, incontinence. It makes you the premier center that you need to be. But I think the challenges that both Sandy and Richard and Gary are alluding to in terms of getting the buy-in, I'm fond of just telling my partners, and when I've talked about this, every patient who walks into the clinic should be a research patient until proven otherwise. Because we all went to medical school as physician scientists. And I can't imagine anybody being interviewed today at a medical school and asked, well, how do you feel about research? And saying, I'm not really interested in it. I don't know that they get into medical school. So it's our burden to advance healthcare. The only way we're going to do it, get cures for cancer or HIV/AIDS or anything, or improve lower obstructive urinary symptoms, is to get new therapies and new devices. And we have to get patients to understand that it's our responsibility to educate them on it.
Yeah, and I